Good afternoon, everyone. I'm going to talk to you today about our study in residential care settings during the COVID-19 pandemic, where we specifically focused on the impact on residents. So the investigator team were myself, Dr. Mary Nevin, Dr. Ciara White, Dr. Andrew Boylson, Pat Boylan, Professor Anthony Staines and Breach Casey, and we all work in the School of Nursing, Psychotherapy and Community Health at DCU. So as you all know, the first confirmed case of COVID-19 in Ireland was on the 29th of February 2020, and the pandemic went on to have a very disproportionate effect in residential care settings, particularly in its first wave between March and July 2020, and 56% of all deaths in the country occurred in these settings. So the aim of this study then was to explore the impact of the COVID-19 pandemic on older people in residential care settings in Ireland outside of the mortality rate. So we adopted a two-phased mixed methods approach. In phase one, staff and residents in residential care settings for older people and their family members were invited to complete an online anonymous survey that we developed specifically for the study. And this was disseminated via our own healthcare contacts and also via Nursing Homes Ireland and SAGE Advocacy Group for Older People, and also on social media. We also undertook semi-structured interviews with family members who had participated in the first phase of the study. So just a few words on our response rates. So in total, 76 people who work in residential care settings completed the survey, and this was made up of managers, persons in charge, owners who are also persons in charge, owner managers and staff members. And you can see the breakdown there of the staff members. There were nurse managers, staff nurses, student nurses, HCAs, cleaning and catering, and one administrator all completed the survey. And the healthcare facilities who responded were pretty much 50-50 HSE facilities and privately owned facilities. In terms of geography, the majority were based in Leinster. There you can see 67% of centres who responded were in the Leinster region, but 13 of the counties nationally were also represented. So that means if you break it down into how many facilities there are in Ireland, roughly speaking, we heard from 1 in 7, 1 in 8 facilities in the country. 30 family members completed the online survey and no residents completed the survey. And for the wonderful interviews, we had 11 interviews conducted remotely with family members and no residents took part. So for the purpose of this presentation, we are going to focus on the results of the staff survey and the one-to-one interviews with family members. So our key findings from both those elements, which we triangulated for the purpose of today's presentation, show, I suppose, not surprisingly, that there were many adverse impacts for residents in terms of both their physical and psychological well-being, but also their wider social effects as well. And family members were also very significantly affected adversely as well, it has to be said. So in response to this question, which was posed in the survey to staff, the question was, what were the main adverse effects, in your opinion, on residents? And you can see there, not surprisingly, they cited that residents really missed their loved ones, that the residents became really isolated and lonely during that period, that really visits through a window was a very poor substitute for seeing a family member in person, and that they were very fearful and anxious about getting the disease and about dying. And this was really echoed as well in the qualitative findings. So we've included some quotes there where a family member said that the isolation was killing their loved one, that they felt that she might die of loneliness in the care setting, and that there was no point in having somebody locked up in a house on their own, seeing nobody and having nothing. That is no way to live, I think we can't lose our sense of humanity at the end of the day. So they were all sentiments expressed about their residents who were in care settings during particularly wave 1 of the pandemic. Another finding was that was noted in the qualitative work was the acknowledgement that, you know, their family member had really declined further than they would have expected them to under normal circumstances during the pandemic. And one person said they could not believe what I could not believe what I saw. My mum had lost a lot of weight in that month. She was grey, drawn. She had weeping eyes, and her lips were all desiccated, very, very dry and dehydrated. I was really taken aback. I was thinking, God, how did she go downhill this quickly? And another participant said they thought she was dying when they rang us, but she did last. I think it was just the fact that she saw family. All she wanted was her family around her. I think that's really profound thought. So one of the other questions we looked at in the staff survey was the level of care, the quality of care provided during the pandemic. And the question we posed there was the usual care of patients reduced or neglected during the pandemic? And you can see there that around 37% of the staff respondents, agreed that or stated that care was neglected during the pandemic. So that's quite worrying. That's quite a large proportion of individuals whose care was neglected. We also asked the question in relation to palliative care. Were you able to meet the palliative care needs of patients during the pandemic? And again, quite a worrying statistic there, where 20% of those who answered the survey said that they were not. So that's worrying. In the qualitative findings, this was further echoed. Families believed that care was reduced, that it had a negative impact on their relatives, and a major reason identified by relatives was their own inability to provide direct care to their loved one during the pandemic because of the visitors' restrictions. And that was a real cause of frustration and upset for them. We knew by looking at her that she wasn't being cared for. You could see it in everything. Her eyes were bad, sores on her lips, bed sores. That never happened before because we would be in every day. And another participant in the interview said, I visited every evening. It was near my work, very much. It was a partnership. The kind of encouraged that. We talked about that before she moved in. You're not handing her over. You're still part of her care. That was very important to me. So you can only imagine the shock and absolute horror when COVID happened, because this is what I was doing with my everyday. So you can really see the level of upset in those comments and those quotes. So another area we looked at in the survey was connectedness with the resident in the residential care setting and their family members. And staff were asked, were residents confined to their own rooms without company for the duration of the pandemic? And if you remember, that was a very long time, several months in wave 1. And you can see there that 33% of respondents said that their loved one or their family member was confined to their own room without company for the pandemic. So if we're trying to link that with a decline in their health and well-being, I suppose it's easy to see how that could happen in those circumstances. The other question we asked staff members to comment on was the remote connectedness during the pandemic for residents. So were residents given, afforded the opportunity to connect with loved ones and family members remotely? And on the face of it, this looks quite encouraging that they told 98% of them said yes, that they were able to connect remotely during the pandemic with their loved ones. But this wasn't really borne out in this apparent positivity was not borne out when you looked at what came back in the qualitative data, where the quality of the connection was really called into question. So maintaining connection with relatives was a constant and was a consistent struggle. and this was raised by family members. And one participant said she certainly would have lost the connection to her grandchildren in a big way, and probably a big connection to us, because she struggled to turn down the TV. She physically couldn't hear us as well when we were outside. Simply, I would offer to hold her hand when I was able to visit. You physically weren't able to do that during the restrictions, so you lost that degree of connection with her as well. And many of the relatives spoke about the difficulties encountered when they attempted to use technology as the sole method of communication with the resident. It was the nature of the interaction on the screen. It was very complicated. She would recognize us, but she wouldn't be able to have sentences. When we were there physically, she would, but on screen she couldn't. She was so old. It was unusual for her to communicate like that. She was in her 90s. And another participant echoed that sentiment and said, but you find it hard because at that age, it's okay to do that, but it's like a one-way conversation. They're not used to that technology. They find it hard. They're not used to it. So I think that agrees with the earlier quotes. And again, related to that same point, the IT technology, family members also described capacity challenges relating to the residential centres' IT infrastructure and staff technological knowledge. Despite their willingness to try to use the technology, one participant said they didn't have Wi-Fi in the nursing home, so I strapped a mobile Wi-Fi unit onto the back of the table so that she was set up ready to go. Another participant said, I don't know how well qualified they were. I would think the whole area of IT was the one that caused us most difficulty, IT and access to IT on one level. And then the same participant said, technology is moving so fast and there is so much more we could do. So that was really, I think alluding to future waves and what could be done to improve that situation and that connectedness. So just moving on then to have a look at social, cultural and educational activities during the pandemic. And the question that was posed on the staff survey, were the residents' social, cultural and educational activities suspended for the COVID-19 period? And you can see there that around 70% of respondents said that they were. And so that is huge, and you can imagine the impact, the adverse impact that would have. And again, that was echoed in the qualitative findings, where the participants said that most of the activities were suspended during the pandemic. And one of the quotes there, I think, illustrates that what was previous was not so much activity. What was previous was so much activity and lots happening, to then just nothing. It all went out the window. And family members described how activities staff were redeployed from those roles to patient care in other areas. And that had a significant impact on the residents' social engagement. So the whole situation is really worrying. It's really unsatisfactory. The social isolation, the lack of movement, the lack of activities. I asked again when I was on with the CEO, can we pay more money? Can we give voluntary contributions to try and bring people in to try and get people? Can you please encourage mum to walk? Can you encourage mum to go down to the lounge? And that was just a quote from one of the participants in the semi-structured interviews. And then another question from the survey, which we looked at, we asked staff to comment on which of the following supports were provided to residents during the pandemic. And you can see that there were some psychological, emotional, spiritual, pastoral, things like mass were still in place, as well as physiotherapy and occupational therapy. So it was, so while a lot of the social and recreational activities were suspended, it was good to at least know that those kind of allied health professional offerings were still provided during the pandemic. And again, that was echoed in the qualitative findings. Relatives observed that efforts by staff were made in some instances to find alternative ways to support the residents. The activity staff are now spending their afternoon bringing people down to one of the lounges and organising Skype calls with family members. So there seemed to have been some improvement at that point. The chef in the nursing home has been cutting everyone's hair. When they were all looking like scarecrows, her hair had been cut. One of the carers went round and varnished everyone's nails and gave them manicures. So there was obviously some kind of redeployment going on within the staff as well to do that in the absence of those who were normally present to do it. And frustrated relatives also tried to offer support themselves. I said to Mum's nursing home, perhaps we can do this. We can bring in extra activity staff. We can help to bring people outside, do whatever we have to do. But the offer wasn't taken up. And you can imagine there was all sorts of reasons, health and safety related, why that wasn't permitted, and it would have been outside the guidelines and the regulations nationally. So in conclusion then, these findings demonstrate that residents were adversely affected physically, psychologically and socially. The study also showed that family members felt that their important role in augmenting care provision normally and connectedness with their relative was very adversely impacted during the pandemic. And while technology was used to support communication, there needs to be a more and a better person-centered approach to its use, as well as adequate staff resources. And all of this should not be seen as a substitute for human contact, because it's not, and it didn't function in that way.